A very good morning to Dr. Munishwaran and viewers who are watching my case presentation today. My name is Muhammad Zulhafizan bin Nur Hizam. Today, I am a student from Bachelor of Medical and Health Science. Would like to present my case presentation for my clinical practice NBCP3912 Clinical Practice Mental Health. As chosen, my topic is the assessment and management of a patient with psychiatric problem, severe major depressive disorder with anxious distress as my topic chosen in my case study writing. Now, let's take a look for the presentation outcome that I hope anyone who watching my case presentation today will get these 5 main points that I have been highlighting in my presentation today. The first one, we will take a look the introduction of severe major depressive disorder with anxious distress. Second one, we will take a look Mrs. A demographic and general health history. The third one, we will take a look mental state examination MSE assessment that I think very crucial in our management for psychiatric patient. The fourth one, the diagnosis and treatment management for Mrs. A case today. The fifth one, we will take a look what are the conclusions that I have been summed up in my case study writing and what are the outcomes that to be expected and actual outcome that have been occurs in Mrs. A's cases. Now, let's take a look what are the understanding severe major depressive disorder with anxious distress. Severe major depressive disorder MDD with anxious distress is a debilitating mental health condition categorized by persistent sadness, loss of interest, and overwhelming anxiety. In this presentation, we will explore the complex disorder through Mrs. A case, 42 years old female woman who depression is deeply intertwined with domestic violence and the cultural barriers. Mrs. A symptoms including constant fear, guilt, dissociation, mind-touching sensations, and passive suicidal thought, highlighting how trauma can be shaped and intensify depressive illness. Her case highlights the crucial need for comprehensive treatment that address both biological and psychological factors while taking account into culture and social context. Now, let's move for my second phase of case presentation, Mrs. A demographic. Mrs. A is a pseudonym for confidential purpose. 42 years old female Malay Muslim, language fluent in Malay but limited in English. Cultural context, traditional values strongly influence her view of her family in roles and marital duties, which I can be simplified. Perempuan perlu berada di dapur. Perempuan perlu taat pada suami. Setiap tindakan perempuan perlu minta keizinan suami, which affected her role as a mother and wife in his family. And the social role, married mother of 3. Mrs. A general health history. Presenting complaint feel very sad, overwhelmed, and trapped in abusive marriage. History of presenting illness. Duration of the symptoms significantly reported for the past 5 and 6 months ago. Core symptoms that we can see in this Mrs. A problem. The first one, pervasive low moods, loss of interest, and severe anxiety. Second one, excessive of guilt, particularly regarding of her children. The third one is insomnia, severe fatigue, and poor concentrations. The fourth one, passive suicidal ideations, but there is a no plan reported from this Mrs. A. Trauma symptom report, this associative episode described as a mind-touching. Major stressor is because of the ongoing violence, physical, psychologically, and the financials. Past medical history, there is a vitamin B12 deficiency that might be contributing to the fatigue in this history of collapse. And there is no other significant medicals and psychiatric problem reported by Mrs. A case. Now, let's take for the third session in this case presentation, which is mental state examination MSE, that very important when we assessing a psychiatric patient. The first criteria that we assessing in Mrs. A, which is appearance and behavior. She come to us in appointment wear very neatly, but she looks very exhausted all the time. She also very have a poor eye contact with us, but we can see there is some tearful that been hiding by her. Also, she a very cooperative patient, but sometimes she cannot hesitate with some points that we ask to her. Second one, we assessing about her mood. She are very empty and scared all the time, especially when she told whatever happened about her marriage. And there is a sad, anxious and tense all the time whenever she came and whenever she shared about marriage and her husband. The third one, we assessing about thought. She thought she is a failure as a mother. Because why? Because she cannot protect her marriage and she also cannot protect her children from beating from her husband. The most important thing is risk passive suicidal thought. That one day she hopes she cannot wake up in the morning, but there is no active plan how she going to work with his thought. The fourth one, perceptions. There is no hallucination reported in this case. She not hearing or seeing any unreal things in her situation, but there has odd mind-touching sensation like disassociation from trauma that happened to her. The fifth one is cognition. She is alert and irritated what happened at her home and what goes on during the clerking session with our psychiatrist. There is a poor concentration that we can see during the clerking session with our specialist. The last one, insight and judgment. She has a very good insight because she knows she is sick and she's looking for help because of her sick. And the judgment, she knows she is in danger in this abusive marriage, but she cannot do anything because of family issue and the very alpha behavior by her husband. And what we have been a clinical impression on in this assessment, which is severe major depressive disorder with anxious distress. Symptoms are severely exacerbated by ongoing domestic violence and trauma. Why psychiatrists decide to diagnose as a severe major depressive disorder MDD with anxious distress? Now we take a look. There is a 5 core points symptom that have been confirmed. This is a MDD situation to Miss A. We can see the first one is depressed mood, empty and scared all the time. We can see also markedly diminished interest anhedonia in her life. There is a significant weight and appetite change for the past 5 and 6 months ago. Also, insomnia, fatigue that sometimes she also reported collapse at home during a very bad fatigue. Feeling of worthlessness and guilt to her children because her cannot protect that marriage and protect her safety of children. Also, diminished ability to think and concentrate whenever a very crucial moment happen in her situation. She cannot concentrate or think properly to decide and to do act in her marriage. The anxious distress because of the tense, restlessness and fear of something awful might be happen in her, also with her children whenever she at home with her husband. Alright, now let's move. What are the comprehensive management and treatment that we already assigned for Miss E into her problem? I know why suddenly Dr. Munishwaran and viewers might be surprised why this case study presentation suddenly changed into this mode. Because during my editing sessions, I noticed there is some mistake that I have remade in my previous presentation. So I come with this remake version to make my management and treatment presentation more proper and fluent for these presentations. Alright, for this case management and treatment, I have been aligned with a 3-phase management that see how the progress of this management in this case study. The first phase is the acute management. What are the early interventions that we can help Miss A to overcome her issue? The second phase, we have been aligned what are the monitoring and relapse prevention for her treatment for the 6 or 12 months. And the third one is what are the physical treatment that we might be considered to proceed to Miss A, for example, electroconductive therapy, if all the treatment we have been given previously are not working with her. Phase 1, acute management. What are the early intervention that we already do for Miss A? For the early intervention, we have been divided into two steps, which is the first one is pharmacology, second one is psychotherapy that might be useful for her. Let's see what are the pharmacotherapy that might be used for the all depression people, also for Miss A case. For pharmacology, there is an antidepressant group. Antidepressant group, there is a first one, tricyclic antidepressant. Second one, monoamine oxidase inhibitors. Third one, atypical antidepressant. The fourth one is serotonin selective reuptake inhibitors. The fifth one is serotonin neuropamine reuptake inhibitors. This is a five main group that already aligned in Kementerian Kesihatan Malaysia guidelines for major depressive treatment. Also for the anxiety treatment, we already assigned for the diazepam, fluoxetine, allopurinol, clopidogrel, and ibuprofen in these cases. For the psychotherapy, we already decide to align a few kind of steps to help her to overcome her issue, which is the first one is cognitive behavior therapy, CBT. Also, the second one is interpersonal psychotherapy. The third one is problem solving. The fourth one, behavioral activations. Also, the fifth one is mindfulness based cognitive therapy that we already assigned to help her to overcome her issue with psychology therapy. For the phase 2, for the continuous and monitoring. For the phase 2, we are focused how to stabilize Miss A condition and the relapse prevention for her in the 6 to 12 months in this kind of treatment. So, for the stabilizing medication, we have been divided into three, which is steriline, aripiprazole, also omega-3 by our psychiatrist. The first one is steriline. Miss A have been given dose to 100 to 150 mg per day titrate depends on her condition, which is have a 70% reduction rate. Rationale why Steriline is still continuous for Miss A in this treatment because RCT demonstrate a 70% reduction in recurrent compared to placebo where the treatment is continued up to 12 months. This already gave safe for malnutrition patient, also safe for Miss A condition. Second one is aripiprazole. She have been taken for 2 to 5 mg per day, which have a reduction rate 52%. The main trials showed 52% decline in relapse rates with aripiprazole that mainly target to residual adenomia and emotional numbness as an acting for the stabilizer for patients. So, the third one is omega-3. Omega-3 show have a 40% relapse reduction. This mechanism reduce the neuroinflammation caused by chronic stress. Trial data show 40% lowers relapse with MDD omega-3 taken by patient can reduce this kind of symptom by patient who face up the depression issue. These are the three of medication that took by Miss A as a maintenance for the 6 to 12 months in this second phase of continuous management. So, in this monitoring and relapse prevention, I have been highlighting what are the medication that we give to sustain and maintaining her condition in a good way. Also, what are the psychosocial intervention that we already provide for her. For first one, psychoeducation. Second one, counseling. Third one, peer intervention. Fourth one, exercise. And fifth one, the relaxation step. Now, what kind of sustained psychosocial support that we help her to do in these cases? The first one is psychoeducation. We educate her to know the depression etiology, medication adherence, also the early sign of relapse. Whatever happened to her, she need to notice all these things are very important to reduce the relapse or any complication happen to her. Then we have a peer support, which is we connect with facilitated group. For example, Pertiwi to share a coping strategy and reduce isolation happen whenever happen in her situation at home. Then we also have a lifestyle integration, which is prescribed home-based exercise. For example, yoga, indoor walking. Also, we added some Islamic elements, which is Islamic realization technique. For example, zikir, also takafur for her anxiety management at home whenever she needs. Last but not least, we need to take a look what kind of advanced and long-term management strategy that we have been assigned that might be due to Miss A cases. Alright, which is the phase 3 is physical treatment. This is the consideration that we have take a look if there is all the treatment given are not practically happen to her situation. Alright, this first one we can see is electroconvulsive therapy ECT. What are the indication when ECT we need to do to Mrs. A cases? The first one is only if failure of 2 antidepressant trials. Alright, acute suicidal crisis or catatonic features. Alright, the protocol of ECT, we need to see that 6 to 12 bilateral session over 3 to 4 weeks must be happen. And then with monthly maintenance, ECT for 6 to 12 months. But for ECT therapy, we also need to consider what kind of barrier that Miss A could not make this happen. Which is the first one is this ECT are required a very careful risk-benefit analysis due to her trauma history. And then the other disassociation risk, also a practical or logistic issue that she need to compromise whenever to start this ECT treatment to her. In my case study writing, I have been highlighting a few of complementary and alternative therapy that might be used in this case because this kind of treatment have been proven at overseas to treat the depressive disorder. The first one is what we call by repetitive transcranial magnetic stimulation. The second one is transcranial direct current stimulation. That this is a neuromodulation option for treatment resistant of depression. Then we have some adjunct like omega-3 fatty acid. If this is proven by some research that by taking 1 or 2 grams per day, omega-3 fatty acid show can reduce some depressive symptom by 25%. Also, the last one is acupuncture. Have been proven by Yin Tang that 12 sessions of acupuncture can significantly reduce the depression symptom by a patient who faced and failure in all of management that have been assigned. As a last part of my case presentation today, we will take a look for a conclusion Miss A recovery journey. Alright, Miss A severe depression and anxiety root in a chronic abuse were successfully managed through a phase and integrity approach. What kind of phase and integrity approach that we have already do for her? The first one is clinical stability. Medication like steriline and therapy, cognitive behavior therapy, significantly reduce the depressive and disassociate symptom. Second one, safety achieved. Coordination with shelter and safety planning enable escape from the abusive environment that always happen to her at home all the time. Third one, empowerment. Skill training and peer support foster resilience, independence, and breaking the cycle of integrational trauma that always abuse her at home all the time this issue happening. Right. What I can be said at the end of these presentations, her progress highlight that effective treatment required addressing both of the biological symptom of depression and the complex social realities of abuse that always need to work together to make this management happen works good in her treatment on this journey. I think that's all from me for this presentation. I hope all of you that watching my presentation can get the 5 points that I've been highlighting at the early of this presentation. That's all from me. Thank you so much for hearing my presentation. Assalamualaikum and a very good morning from Muhammad Zulhafizan bin Nur Hizam.